But I would like to welcome you all first. And this is after the first prelude last year, we actually expanded the scope of this meeting. So we are actually want to touch a cross section of each year of a rare disorder, either a system or a disease. First, I just want to actually give a little brief scope why we are doing this and what we are working and why we have all you together. So what is a rare disease? So rare disease is AKA is orphan disease and is a condition that actually affects, by definition, less than 200,000 people in US. However, the reality is 1 in 10 people in US are affected with a rare disorder. And if you want to gather all the people affected with any kind of rare disorder, it will actually make the population of Texas. So even this is rare, this is truly common. So this is why we chose the title for this year is Rare is Common. So if you look as a general, how we can categorize a rare disorder? So with a non-genetic defect, a clinical phenotype, unknown gene, but with a given either clinical or pathologic phenotype, or we don't know anything about, but there is a constellation of findings to give some phenotype. So as Dr. Brady reiterated, Gaucher disease is a great example. 1 gene, 1 protein, clinical phenotype, but we know how complicated Gaucher disease is. And I'm going to actually touch base as a second disorder that our center is really invested in is eosinophilic esophagitis, which is a combination of finding. There is a pathology to that, but the gene or genes are not known yet. And if we take the transient hypoglycemia of infancy, there is a very well-known phenotype. There is a laboratory finding, but we don't know what is the protein, what contributes to this condition. So patients and physicians or anybody who has touched by a rare disorder, we like to actually give zebra. Because zebras are rare, but they still come with the hoof beats. And that's why, a lot of companies that is around us today chose to have a zebra as their logos. But how the patients think about themselves with a rare disorder, actually, one of our patients described herself as a unicorn. Because unicorn is not only rare, but is somewhat mystical and mythical. And this is what the sentiment of the patients with a rare disorder is. They're mostly told it's in their head, that doesn't exist. They need to go get checked, so on and so forth. So there is a big, long saga with a patient who has a rare disorder. What do we need to do to help these patients? So basically, we need to think differently. So we need to put every knowledge we put so far taught and the system so far we are invested in, put aside and just put and take all these the glasses off and think differently. So because all the information is biased. The reason is the rare disorders are rare, so everything is written about them and nothing has been actually very diligently worked about them. And evidence-based medicine, which is actually the in vogue trend right now, has truly have limitations for rare disorders. And unfortunately, we learned that these patients do not read the books nor the publications about them. And similarly, lack of identification and many presentations can overlap with each other, which actually Sean is going to give a great presentation today of a patient that we diagnosed. I'm not going to give the clues, but this is an example, and there is a big lack in diagnosis. So I just want to bring a mechanistic approach to a rare disorder. So how we can do that? So obviously, we start with the pathophysiology. And then what happens to the natural history and the effects of intervention. So obviously, everybody wants to find a treatment, drug, and help these patients. So then we move to trials and efficacy and study design and the IND and endpoint identification and development. However, when we have a patient in the second phase, usually they are at the top of the iceberg, and we still have all these patients at the bottom of the iceberg. We still have a lag in identification. So Dr. Brady presented in a great way is a mechanistic approach how we can actually approach the lysosomal disease to develop a therapy. So from this model, actually, what moved into from ERT is a molecular chaperone therapy. So basically, the proteins are misfolded in the cell that would actually lead to a functional deficiency of the protein. And then also the substrate that accumulates, you can decrease with the ERT, but there is actually ongoing substrate reduction therapies. And also, we need to probably target multiple pathways to provide a cure for these patients. So similar, again, from in Gaucher disease, so from cells to the actual organelle, we're moving forward. So the ERT has been developed as macrophage targeted. In the first picture, you're seeing what's called the Gaucher cell. They're the pathognomonic. And then you see these tubular structures. There are the actually stored substrate that we can actually apply substrate reduction and enzyme replacement therapy to clear. And now we are just into the lysosome. So what are the effects of this both substrate, actually, the accumulation and the enzyme deficiency and the abnormal protein for the lysosomes? So now we are actually understanding that there are multiple effects that we weren't quite actually had an understanding about. So it affects autophagy, which is a lysosomal function. It affects lipid pathways. So there we use some of the biomarkers as lipids, but we didn't know what exactly is that. And it talks about crosstalks with nucleus, with the mitochondria. So it doesn't all just stay in that little organelle, but expands. So that's why all these conditions are very complex. So what do we do to understand a disease? So natural history studies. What do? We track the course disease over time. So the main endpoint to this is to understand what happens so that you can actually develop clinical outcome measures that you can apply in the studies and for your drug, actually, that's development process. It is the pillar of the epidemiologic research on rare conditions. However, natural history studies are not registries. So they are not phase 2, phase 4 studies. They are not actually designed to understand the patient psychology, the interaction living with the disease. So the major endpoint is to inform drug development. So one of our mistakes is actually to move our registries as a natural history study, which misses a lot of points in each disorder. So Tanya and Cindy, they both represent Gaucher disease advocacy organizations, can attest that this is the true version. And tomorrow we have a session, please attend. We invited actually Dr. House. He is the director of Marshall Field Clinic, but he is working with NCATS to develop a patient-oriented and government-sponsored registry. And obviously the patient information doesn't belong to anyone except for the patient, but it should be useful for all the people who wants to touch the life of a patient, should be made available. So the second example that I mentioned is the eosinophilic esophagitis. There is a biopsy finding. But obviously, like every similar disorder, the patient comes about 4 years later into the diagnosis. And they usually come with actually this significant swallowing difficulties. They already been have undergone a surgical instrumentation for the stricture in the esophagus. But obviously, to develop that pathology, you probably need another 10 years for the disease to occur, and some of the findings actually are irreversible. So eosinophilic esophagitis is a pathologic definition. It's probably similar to diabetes, and there are many actually co-founders leading to that. So actually, EE is one of the government FDA's project to develop a registry on that. So actually, there are several centers collaborating to understand the natural history of the disease. And the questions, few of them are asked is describe all the phenotypes, study timelines to develop a disease-oriented approach and drug, and they represent the current practices for treatment. But to have a drug approved by the FDA, you need substantial evidence. So what is a substantial evidence? So you design a study which is adequate and well-controlled to test the effectiveness. And so what is a clinically meaningful endpoint again for effectiveness? So it is a direct measure of how a patient functions, feels, and survives. So if you see that there is not a lab value here, there is not a pathology, it is the patient. However, the rarity of the conditions actually led us to use some surrogate markers that Dr. Aubrey is going to talk about today, and has a roundtable discussion tomorrow. How do we use the surrogate markers for identification? They have a great neonatal screening program in Canada. And also to modify therapy, as in Fabry disease, with the help of biomarkers. And what is the treatment benefit? So the impact of treatment on how a patient survives, feels, or functions versus the surrogate endpoints. Surrogate endpoints are usually used for a regular approval, but not for fast-track approval. However, we know most medications actually in the rare disease world have been actually approved through a surrogate marker, such as the pathology in Fabry disease. So what we learned from these two examples, EOE and Gaucher disease. So drug approval is a long, tedious task that requires multiple steps and long time. And disease heterogeneity and lack of clinical meaningful endpoints are the major drawbacks in rare disorders because it's so heterogeneous. And so we just need to understand how the disease occurs and how it relates to pathology, and before we move to the drug screening project. So thank you very much, and I welcome everybody again. And I actually want to dedicate these sessions from today on. We hope that we do this annually. So we pledge and strive that we lose no child and no patient at some time for a rare disorder. Thank you.